بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أعزائي طلاب وطالبات المستوى الرابع ضمن برنامج بكالوريوس طب وجراحة الفم والأسنان، أهلا بكم في مستهل اللقاء 11 ضمن لقاءاتنا التعليمية في مقرر طب الفم. في اللقاءات السابقة في الثلاث اللقاءات الأخيرة تحدثنا عن الأورال ulcerative lesions. We had talking about oral ulcers 1, oral ulcers 2 and oral ulcers part 3. In these two lectures, the 11th lectures and also the 12th, the next lecture, we will talk about the white lesions. We had finished the oral ulcerative lesions and we will talk about other category of oral lesions, which is the white lesions. The white lesions, which is presented in the oral cavity as a white existence lesions. In this lecture, we will talk about part 1 oral white lesions, the references of this lecture, the handbook oral maxillofacial medicine, and also the oral medicine and pathology at a glance for Dr. Crispian Scully. At the end of this lecture, the student should be able to diagnose and differentiate the white lesions from other oral white lesions or other lesions, and also the student should be able to diagnose the white lesions and correlate their causes with the clinical features, and also the student should be able to reach the definite diagnosis and provide the best management for those white lesions. The student at the end of this lecture also should be able to integrate the clinical findings of the white lesions with the patient complaint and the systemic condition. In this lecture, which is the part 1 of oral white lesions, we will talk about the pattern of white patches, the causes of white patches, and also we'll talk about some lesions which presented in the oral cavity as a white lesions. We will talk about lichen planus first of all, regarding its pathology, pathogenesis, etiology, and differential diagnosis, how to diagnose it and how to manage and treat the patients with lichen planus. Also we'll talk about lichenoid reaction, lupus erythematosus, as well as chemical burn. All these 4 lesions are presented in the oral cavity as a white lesions. We'll talk about each of these 4 lesions, starting from them, their etiology and pathogenesis, and the clinical diagnosis and differential diagnosis, and also the management, and maybe we'll talk about the investigations needed to confirm the final diagnosis and also the management of all of these white lesions. In this lecture, we'll talk about the lichen planus, lichenoid reaction, and lupus erythematosus and chemical burn as a white lesions. So these lesions are presented clinically in the oral cavity as a white lesions. Patterns of white patches in general. Some of white patches might be presented with pain and the other might be presented painless. So some of the white lesions associated with pain and the others associated with non-pain or non-associated with any painful conditions. The white patches which often associated with pain, lichenoid reactions, lupus erythematosus, lichen planus, and the chemical burn. So these 4 white lesions are commonly or oftenly associated with pain. So one of the symptoms of these lesions, your patient complaining from pain. So you can differentiate those white lesions with other white lesions which associated with pain. The white patches which are rarely associated with pain or commonly associated with non-pain or painless condition, the pseudomembranous candidiasis and chronic hyperplastic candidosis. These 2 white lesions are associated with candidal infection, and white spongiovus, which is a hereditary condition. We will talk about it in detail and this keratosis congenita, also we'll talk about it in detail, and the frictional keratosis, which is a response of the cell to the continuous friction. Also, the white patches, which are rarely associated with pain, myclonic stomatitis, which is the inflammation of the minor salivary gland duct, openings due to smoking, and also leukoplakia. The white lesions cannot associated with any obvious clear risk factor or cannot categorized under any other white lesion, so we can call it leukoplakia. Squamous cell carcinoma, which is the most dangerous, aggressive, malignant lesion of the white lesions. Unfortunately, this non-associated with pain. As well as we has the skin graft. We had talking about it in the normal variations, and the hairy leukoplakia, biostomatitis vegetans. All these are white lesions associated with non-pain or painless condition, as well as the submucous fibrosis. So the general causes of white patches: the white patches may develop within oral mucosa due to either trauma or due to infection or due to immune related condition. Infection might be candidiasis, which is the most commonly, or fungal infection in general, the most commonly white lesions due to infections. Immune related, like the lichen planus and lupus erythematosus, and diseases such as neoplastic lesions. So the white lesions in general may be due to developmental anomalies like the white sponginovus or dyskeratosis congenita, and maybe due to neoplastic changes such as the squamous cell carcinoma, or maybe due to traumatic, such as the chemical burn as a chemical trauma, or due to inflammatory process. General speaking, at the first, if your patient complaining from white lesion, you should start your clinical diagnosis or clinical examination of this lesion by evaluating or assessing if this lesion can be rubbed off with the piece of gauze or not. So you need to take a piece of gauze and rubbing off this lesion, and you will see if this lesion can be rubbed off, can be removed from the attached tissue. So it might be a candidosis or materia alba or burn. So these three white lesions are associated with superficial layer which can be rubbed off, can be removed out. The lesion which cannot be rubbed off, so it is firmly attached to the underlying tissue. If it is diffused, spread out over wide area of the oral mucosa, so it can be categorized as a lichen planus or white sponginovus or proliferative verrucous leukoplakia. So these three lesions cannot be rubbed off and are widely spread, diffused.
So we need to differentiate those lesions from the others which are not diffused, not spread out over areas, large areas in the oral mucosa, such as leukoplakia, frictional keratosis, dyskeratosis congenita, as well as the lupus erythematosus and the syphilis. All these also white lesions cannot be rubbed off but are in non-diffused pattern. White patches are usually painless, although the patient can complain from discomfort and discomfort. This discomfort can be resulted from erosion or ulceration, particularly in white lesion, which is the lichen planus. Some white lesions are pre-malignant lesions, and therefore you need to take a biopsy to reach the final diagnosis, and you will see in the histopathological results if there is any stages of dysplastic changes. So you will see if there is any stage of malignancy transformation for those lesions. The white patches also may be presented in the oral cavity as a localized or widespread throughout the mouth. The localized white patches suggest a traumatic, commonly the traumatic or the neoplastic etiologies, presented most commonly as localized white patches. But the widespread white lesions suggest a systemic or immunological or hereditary condition. So hereditary conditions related white lesions or immunological related white lesions, as well as systemic condition related white lesions, most commonly presented as a widespread white lesions. But the localized patterns of white lesions most commonly associated with traumatic or neoplastic origins or causes. The first white lesion we'll talk about in detail is the lichen planus. Lichen planus, as we mentioned above or before in the last lectures, this is one of the more prevalent mucocutaneous disorders. Mucocutaneous, so we will talk about skin lesions as well as oral mucosal lesions. So it is associated with lesions in the skin and lesions in the oral mucosa. The cause of lichen planus is rarely not known, although it is an immunologically mediated, as proven and founded. The T lymphocyte mediated destruction of the basal keratinocyte cells and production of more amount of keratin, which we call it hyperkeratinization, produces the characteristic clinical lesions. As we see in this picture, this is the result of production or hyperkeratinization. The Wickham ray radiated from white patch, as we see in this clinical picture. Clinically, lichen planus present as a white patches or stray that may affect any oral site, and also typically with a symmetric and bilateral distribution. So one of the key diagnostics of the lichen planus, its occurrence bilaterally. Clinical appearance variable differences, and at least there is founded to be 6 forms have been also described. Reticular pattern, first one, or may be presented as a papular pattern or plaque-like. Also atrophic lichen planus also can be presented erosive lichen planus, as well as, which is rarely presented, as the bullous lichen planus. When we talk about those forms of the clinical presentations of lichen planus, we should remember the lecture about the clinical prescription of lesions, in which we had talked about the how to describe the lesion. It's a papular from papules, or black, or atrophic erosive erosion, or bullous. Clinically also, as this lesion is a mucocutaneous lesion, the cutaneous lesions of lichen planus presented as a purple pleuritic papules most frequently occur in the flexor surfaces of the arms and legs. The flexor surfaces of the arms in this picture, and also the flexor surfaces of the legs. This is the mucocutaneous lesions of the cutaneous lesions of lichen planus, and this is the mucous lesions, and this picture is the cutaneous lesions. The fine white patches or lines known as a Wickham's ray. As we mentioned before, the lichen planus clinically as presented with white patches associated with radiated striae. These radiated striae are the Wickham's ray. So it seems to be a pathognomic feature for lichen planus, and may be seen on the surface of these papules of the cutaneous lesions. Differential diagnosis: the lesions which resemble the lichen planus clinically, lichenoid drug reaction and epithelial dysplasia, as well as reactive keratosis. So we need to differentiate clinically and histologically those lesions from lichen planus. How we can diagnose the lichen planus? The clinical diagnosis of the oral lichen planus is aided by the presence of cutaneous lesions. As we mentioned before, it is a mucocutaneous white lesions, so you need to find out these the cutaneous lesions. A mucosal biopsy will show a hyperkeratinized epithelium and basal cell destruction, as well as you will find histopathologically a band-like infiltrate of T lymphocytes in the superficial connective tissue. Management of lichen planus: the patient should be reassured of the benign nature of the lesion, so you need to make a reassurance for your patient. However, the pre-existing lichen planus has also occasionally associated with development of oral cancer if it is pre-existed for a long time, and also if there is a risk factors for oral cancer are presented. Management: how we need to manage lichen planus. The first line treatment is symptomatic treatment. For the symptomatic cases, prescribing antiseptic mouthwash combined with topical steroid to increase the healing capacity and reduce the inflammatory process. These topical steroids may be in the form of either hydrocortisone hemisuccinate pellets to 2.5 milligram, or you can prescribe betamethasone sodium phosphate or 0.5 milligram, or also you can instruct the patient to dissolve this betamethasone sodium phosphate on the affected, dissolve it on the affected area 2 to 4 times daily. Also, you may need to prescribe a short course of systemic steroid therapy if the patient complaining from acute symptoms, and also in the cases involving widespread ulcerations, so the patient can't eat or can't speech. Also, if there is an erythema and pain, you need to prescribe a systemic steroid for your patient. Other drugs also can be helpful in treatment of the lichen planus, such as cyclosporines and the topical tacrolimus and systemic mycophenolate. All these drugs can be helpful to treat lichen planus. Also, if the patient complaining from stress, which may be presented with association with lichen planus, so it can be considered a precipitating factor for lichen planus, especially in the older patients. So you can prescribe an anxiolytics for your patients, such as tricyclic antidepressants, which found to be helpful in selected cases. The second lesion of this lecture is the lichenoid reaction, and we had mentioned it above in the ulcerative lesions, so named because the similarity of clinically and histologically to lichen planus presentation, so we called it lichenoid from lichen planus. Systemic drugs that has founded to be implicated in as the causes of lichen planus are antihypertensives, hypoglycemic, and non-steroidal anti-inflammatory drugs. Also, the direct contact with dental restorative materials should be also evaluated, which can be cause of lichenoid reaction. So it is very important to take the past medical history and make a clinically definite and clear clinical examination. The clinical features: these lesions can occur at any oral site, in contrast to lichen planus. As we mentioned above, the lichen planus most commonly bilateral, symmetrical, but the lichenoid reaction commonly presented asymmetrical in pattern. May involve the palate. A site is not associated with lichen planus. Differential diagnosis: the lichen planus, epithelial dysplasia, as well as reactive keratosis. How to diagnose it? Oral lesions which develop few weeks after institution of a specific therapy. So these therapies associated with lichen planus. Lichenoid reaction to composite or amalgam materials, as we see in this clinical picture. This is a white lesion, a typical pattern of the Wickham's ray and white patch. This is a lichenoid reaction associated with amalgam restoration. Mucosal biopsy is often helpful in supporting the diagnosis of the lichenoid reaction, in which we use indirect immunofluorescence, which diagnosed the drug-induced lichenoid reaction. Management of lichenoid reaction: first of all, if this patient taking a medication associated with lichenoid reaction, you need to refer your patient to the physician to change the therapy. Reaction to amalgam: you need to replace these restorations with alternative materials, and we will find a resolution of the mucosal lesions in few weeks, and in the short term, topical anti-inflammatory agents such as steroids can relieve the patient's symptoms. Lupus erythematosus: the lupus erythematosus cause is an autoimmune disorder, so there is a production of anti-nuclear autoantibodies. The anti-nuclear autoantibodies is the main cause of lupus erythematosus. Immune complexes are formed and deposited along the basal cell layer, causing basal cell damage. The systemic lupus erythematosus. Systemic means multi-system, so affects many systems such as kidney of the patient, pulmonary, the lungs, and the cardiac, as well as joints of the patient. And also the other type is the discoid lupus erythematosus. In discoid lupus erythematosus is confined just to the skin of the patient, but the oral lesions developed in 15% of the patients. Clinical features. The discoid lupus erythematosus clinically presented as a discrete, raised erythematous, scaly patches. So it is a patches which is scaly, erythematous, raised and discrete, and also can be presented as a lax on the sun exposed area. Atrophic, leading to atrophic hypopigmented scars. The oral lesions are localized striated, so there is a stray, keratotic, and erythematous patches resemble the lichen planus. This clinical picture of the mucosal lupus erythematosus. The patient may presented with a butterfly rash on the skin of the malar process, the zygomatic process. So the patient's face, there is a erythematous wide patch bilaterally resemble the butterfly on the skin of the face, and associated with xeristomia and xerophthalmia, which fulfill the criteria of secondary Sjogren syndrome. Differential diagnosis: lichen planus, ectopic geographic tank, and psoriasis, as well as electrogalvanic lesions. How we can diagnose the lupus erythematosus? First of all, you need to perform a serological test to find if there is any evidence of the presence of autoantibodies. As we mentioned, it is related to autoimmune factor. Is important for the diagnosis of systemic lupus erythematosus. Histological examination, we will find a basal cell destruction and basement membrane thickening, as well as lymphocytic infiltration in the superficial connective tissues. In the immunofluorescence test, the histopathologist will find a granular immune deposits along the basement membrane. We called it a lupus band test. Management of lupus erythematosus, the same as the management of lichen planus. Finally, in this lecture, the chemical burn. Chemical burn, from its name, it is due to the chemical action of aspirin on the superficial layers of mucosa. So it is a superficial chemical injury for the cells, for the superficial oral mucosa, due to topical application of the aspirin tablets next to the tooth, which is painful. The cause of this chemical burn is the low pH of the aspirin, so it is an acidic material, lead to erythema and tissue necrosis, which subsequently resulted in coagulative necrosis and formation of the white sloughing area on the surface. So this lesion is one of the lesions which can be rubbed off due to the presence of the superficial slough white lesion. The chemical burn clinically appear as a white friable slough that can be easily removed, as we mentioned, leaving a bed of erythema and ulceration, which then will be painful. The most frequently involved site is the buccal sulcus or the alveolar attached gingiva, at which the patient put the aspirin tablet. Differential diagnosis: candidiasis, erosive lichen planus, traumatic ulcer are the similarities with chemical burn. How to diagnose it? The diagnosis will be established on the clinical examination and the history of taking aspirin, which is topically applied. Biopsy here will be not usually required, but if performed will show non-specific ulcerations and fibrinous exudate, so we don't need to perform any biopsy procedure for the chemical burn. The management, we should remove the cause, so the patient should stop his habit about topical application of aspirin to treat dental pain. So you will advise him to seek an clinical advice from the dental clinic. It's important also to keep the mouth clean using antiseptic mouthwash or bicarbonate of soda that should rinse several times daily until the healing occurs, the healing which is of the lesions which is resulted from the ulcerations of the removal of the slough. In conclusion, in this lecture, which is the part 1 lecture of the white lesions lectures, we had talking about lichen planus, lichenoid reaction, lupus erythematosus, as well as we had talking about the clinical or the chemical burn. The assignment of this lecture is the clinical case presentations, and this assignment and its explanation will be provided in the assignment part of the course as a Word document titled Assignment 12. Thank you very much.